Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're glad you joined us. Before we begin, I'd like to thank our sponsors, Aultman Health Systems, Studio Arts and Glass, and Genier Appraisals and Liquidations. Today, Brad and I are broadcasting from our administrative offices, and our very special guest is Dr. Chase Beach, General Surgeon at Aultman General Surgery. Good morning, Dr. Beach, and welcome back to the show.
Morning. Thanks for having me again.
Okay, Aultman General Surgery specializes in general surgery with a wide scope of procedures, including the latest in robotic-assisted surgeries for the highest level of comprehensive surgical care. State-of-the-art treatments include robotic-assisted minimally invasive procedures, colon and rectal care surgeries, comprehensive breast care, abdominal and gallbladder surgeries, and hernia surgeries. This morning, we're going to talk with Dr. Beach about robotic surgery and other procedures provided by Aultman General Surgery. We'd like to remind our listeners today that our program is also available on our podcast. Just look for Health Matters with the Medicine Center Pharmacy in your favorite podcast app, and please subscribe.
Dr. Beach, welcome back to the show. Good to see you. Please introduce yourself to our listeners and tell a little about yourself and your background in training and how long you've been at Aultman General Surgery.
Yeah, so, well, thanks for having me back. Just to kind of remind everybody, so I trained at Western Reserve Hospital. It's a small community hospital just outside of Akron in Cuyahoga Falls. So 5 years of training there, then joined on here after that. So I've been here almost 2 years now. It'll be 2 years in August. Since I've been over this way. I've got a breadth of general surgery is kind of my area of interest. I did not do any specialized fellowships, but so I do a little bit of everything, including colorectal surgery, which we'll talk a little bit about today, breast, gallbladders, hernias, what we call lumps and bumps, little lipomas or masses that need excised, do hemorrhoid surgery, and so a little bit of everything. So that's why they call it general surgery, right?
No gallbladder? You do gallbladders?
Yeah, gallbladders as well. Yep.
I got a suture about, maybe 6 inches long across my belly from 35 years ago or something like that. I understand now they just suck that baby right out,
huh? Yeah, we try not to make that big incision if we can help it. We still, every once in a while, you get a real bad one, or the inflammation's too crazy to see things. So as a safety thing, every once in a while, people still get that old school open incision here and there, but we don't take that decision too lightly and try not to do too many of those if we can help it. But I wouldn't promise that it's impossible to get that one nowadays still. So
it still hurts. I'll tell you. What is it?
Wasn't me. That's all I know.
Scar tissue or whatever,
Yeah. That's again another reason why we try to make those big cuts if we can help it.
Oh, I see. Okay. All right. So anything other than what you just said that you would perform surgery on various?
I think that covered the breadth of it. Pretty much anything in the belly is the big stuff. But like I said, the little lumps and bumps, obviously we also, my partners also cover trauma. So there's occasionally, some traumatic injuries and things like that we handle and deal with, or, punctured lungs and things like that. So we'll do a little bit of that here and there, but
they used to, when they had the belly open, they used to take something else out. I can't remember what it was. But they don't do it anymore.
Probably the appendix.
Correct.
Yeah.
Because they did take mine out too.
Yeah, they used to do that a lot, prophylactically, like even for hysterectomies that, if you're just in there for a hysterectomy, they're like, oh, we'll take your appendix too. People started having occasional complications here and there, and we realized it really wasn't worth the risk.
Sure.
Of
over the years, I've heard that the appendix does nothing, but then once in a while somebody says, oh, it does this and does that. Well, what does it do? Anything?
So there's some evidence that it helps with kind of inflammatory processes and maybe does some gut bacteria kind of regulation and inflammatory markers, but it's one of those things that as soon as it starts causing problems, it's really not worth keeping.
Sure.
And you won't miss it. I can promise you that if you're having trouble with it.
How large is it? How large is the appendix?
Yeah, good question. So a normal appendix is probably smaller than your pinky. It's really just this little appendage that comes off the side of the end of your colon there on that right lower side.
Okay.
And it's just this little guy, but once they get infected and inflamed, they can pretty quickly get bigger than your pinky, and if they rupture, then that's a whole nother set of problems too.
And it is very close to the gallbladder. Is that correct?
It is not. So it's on the same side, but your gallbladder is in the right upper side underneath your liver, and almost underneath your rib cage a little bit. And the appendix is down in your right lower side, downward in your pelvis.
Right off the liver, right? The gallbladder.
The gallbladder is off the liver. The appendix is off the colon.
Okay. Okay. So March is colorectal cancer awareness month. Does colorectal cancer affect a lot of people?
Yeah, I had to look up the newest statistics, but about 150,000 people a year in the U.S. Are diagnosed every year with colorectal cancer.
Jeez. What are common risk factors?
So the biggest things that we look at: obesity, diabetes, tobacco and alcohol. Not surprisingly, one more thing that can cause cancer, because it causes cancer with just about everything else. Sure. Red meat, processed meat, if you're eating that daily, seems to increase your colorectal risk factors. So those are the big things.
So we should eat beef, red meat once a week only, or
yeah, that's the hard part. There's not a lot of good. The studies that we have tell you that it's a risk factor, but it's hard for them to make true recommendations on how often it's safe, right? But then everything, unfortunately nowadays, right, everything's got something wrong with it, and you could make the argument that nothing's
you can't eat anything anymore.
I know, right? And if it's processed, it is just
crazy.
I know. You can just grow your own stuff. I guess that's the best. I don't know.
Yeah,
but so to tell you a specific number, but you just moderation. Everything in moderation is probably the best answer.
In my lifetime, I think like coffee. I think coffee's good, coffee's bad, coffee's good, coffee's good. This has been on and off and on. This has been going on for hundreds of years. I'm thinking, my God, I love coffee. Okay,
stick with it. Again, there's always something. There's always this joke in medicine that if you have a certain opinion, there's always some kind of research paper you can find to back up your opinion. And that's our job, is to try and put all that information together as best we can. But there's always a little bit of new stuff here and there, and things change, and we get new information, all the time. That's why it's called practicing medicine, right?
Okay, interesting.
So what other impacts on colorectal health can diet have?
Yeah, so I mean, the biggest thing, especially from a maintaining a regular, your bowel movements be regular is probably one of the better things that I can tell you. And the best way to do that is fiber. The biggest things we think of from a natural, eating standpoint is your, fruits and vegetables. Eating regular fruits and vegetables is probably the best thing, colon health, that you can do. Making sure that you're not constipated, that adds on a lot of extra issues, not necessarily just constipation, colorectal wise from a cancer standpoint, but can add other issues, including hemorrhoids or diverticulosis and diverticulitis, which is, if you know about it, you're aware that can have its own sets of issues. And so keeping yourself regular is the biggest thing. There's certain vitamins that have shown some benefit: B6, calcium, vitamin D, magnesium. And testing those levels with your family doc is never a bad idea, but so a daily multivitamin and making sure you're regular with your fiber is a good thing. If you're not somebody that eats a lot of fruits and vegetables, there's a ton of supplements out nowadays. I tell, if you just go into your local pharmacy, there's down that aisle, there's the powder that everybody thinks about, the Metamucil stuff that you can mix in with whatever your morning coffee or whatever, but there's gummies, there's pills. I saw crackers the other day. There's this fiber crackers, and obviously you have the granola bars that are trying to increase your fiber intake. So there's a lot of ways to get it in. But if you can kind of start keeping an eye on that stuff, especially in Northeast Ohio. We're meats and potatoes up here, and we don't get the best fiber in our diet like we should. And so if you can supplement some way, that's always a plus.
What about sushi? Okay, this is a very popular
Yeah.
food, and it's just to kill the bacteria. And I was listening to somebody the other day. Oh, well, I put a lot of cinnamon on it. And he says, I don't know, there's no bacteria left in. And I said, okay. I said,
I can't speak intelligently on the use of cinnamon as an antibacterial, to be honest with you.
I thought, wait a minute.
I mean, I guess it works. I mean, in theory, right? Sushi's a pretty prevalent thing. It's fairly regulated as long as you're not getting that at a gas station. You probably should be okay. But I mean, like with anything, right? If you're eating fish every day, they worry about mercury levels and all this other stuff. So everything in moderation. But there is some evidence that would fish be a better option because it's not a red meat. Possibly for colorectal, cancer. But it's tough.
Amazing. It just kills me that people eat raw fish, and I'm thinking
it's good. I like it.
Well, okay, I know.
To each their own.
Well, okay. Are we due for a break, Brad?
Yeah.
Okay. First break, say it, doctor. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. Friends, just a reminder, just stop by the pharmacy and talk to our pharmacist about our new Health Matters drug savings program. We want to help you stay well and save money.
All right, doctor, we talked a little bit about diet. How about obesity or other healthcare conditions? How do they play a role in colorectal health?
Yeah, so we touched on that briefly as well. But yeah, both obesity and diabetes, which usually go pretty hand in hand, do both increase your risk for colorectal cancer, and that goes, unfortunately, right along with everything. The healthier overall your body, then probably the better chance your body has to, fight off any of these types of diseases and issues.
Is it true that colorectal cancer is the only preventable type of cancer if it's detected early enough?
Yeah, so that's the nice thing about doing your screenings, and that's why we, as medical professionals, we try and educate people and to encourage them to get their colonoscopies, early on, because it truly is. I mean, I just had a gentleman in my office yesterday who was recommended. He had some polyps on a prior colonoscopy. He was recommended to come back in 5 years. He waited 10 years and now he has cancer. And he's an older gentleman and could a colonoscopy is a much easier surgery and procedure than doing removing part of your colon. And it's early enough and you should be fine, but it's obviously a bigger surgery. And if we can avoid that kind of stuff by doing our screenings and removing these polyps before they start causing a problem, it's much easier on everybody, for sure, especially the patient.
Well, I'm hearing that as when you age into the 70s or 80s, that they don't recommend a colonoscopy anymore. Is that true?
It depends, and I get the very similar questions with because I do some breast as well with mammograms. Like, when do we stop? Like, what? And so what I like to tell my patients, I really base it more on your functional status. If you are active and healthy and you're living alone and you're able to do all the things and go to the store and drive down the street and, it's worth it from my standpoint to do these preventative measures, whether it's a mammogram or colonoscopy, because if there is something, it's easier to catch it early, and we can do something about it, or, just a quick procedure versus, obviously if you have trouble getting around and your health isn't the greatest and, we're worried about putting you even under a gentle anesthetic for a colonoscopy, a little bit of sedation, is it worth it? Maybe not, because most of these colon cancers are fairly slow growing. They usually start out as polyps and slowly increase from there in terms of their complexity. But if we can catch them early, then if you're 80 years old and you're doing great, maybe you take one pill for hypertension, Could you tolerate a colonoscopy, and that give you another 10 years of something you don't have to worry about? And that may be worth it for you.
Oh, interesting. When do you recommend your first colonoscopy? At what age?
Yeah, so good question. Even just in my time as a physician, things are changing a little bit. It used to be 50. Some of the newer recommendations are coming out as 45. They're realizing that some of these patients, the younger patients in the 40 to 50 age group, are actually, the numbers are increasing. And so catching, again, same kind of thing, catching some of these things earlier is better, because then we can catch them before they become a problem, and like I said, even avoid a surgery, which is a plus. So some of the newer recommendations are getting down to 45, and the insurance companies are really starting to pick up on that too, because they realize it's a cost benefit for them, which is all they're in it for, unfortunately. So the newer thing, if you're 45, then it's definitely worth a conversation with your family doc.
Are there statistics on colon cancer more so in women or in men?
That's a good question. I don't know that off the top of my head. So I'd have to look up those numbers, but at least on the in the back of my mind, at least, and based on my experience, there's not really a prevalence one way or the other. I'm sure there's probably more of a prevalence for men if I had to guess, but that's probably more diet and smoking related kind of thing. But
Sure.
I don't have those numbers in front of me.
Very interesting. So, is robotic assisted surgery conducted for this type of condition?
Absolutely, and it's great for this kind of thing. For those of you who aren't familiar with robotic surgery, it really adds an extra element from the surgeon, and really gives us a lot of more dexterity during surgery that we're unable to accomplish laparoscopically.
Interesting. Okay. When it comes to robotic assisted surgery in general, are there risks or complications associated with a robotic?
Yeah, so they're about the same. And again, obviously, it depends on surgeon's experience and how many of these they're doing. But you could say that with any procedure. The laparoscopic to robotic, conversion, is fairly similar. There's some nuances to the robot, but as you get enough of those cases under your belt, there's definitely a benefit especially for the colorectal stuff. But there are plenty of surgeons who are doing these laparoscopically, that are comfortable that way, and that's the way they do them, and have fantastic outcomes. So don't feel I have to have the robot. That's not necessarily the case, but from a surgeon's standpoint, it definitely adds a little bit more dexterity, if that's available to us.
Okay, doctor, how close are we to you? The doctor walks into the surgical suite, presses a couple buttons, and says, "Okay, robot, take care of this. I'll be back. I want to get some coffee."
Yeah. Go play a round of golf, and
I'll be back in an hour or two. You get this job done. Okay.
Right?
I gotta go have a cup of coffee.
Right. No. It's not quite like that. That would be nice and make my job a little easier. But no, it's when we say robotic, it really is a tool. Is essentially what it is. That we are the ones in control of the machine. It is just allowing us to do more things than we are able to do on our own with the instruments that we had prior to the robot.
How would you describe that? I mean, okay, we've had many physicians on the program that are work with robotic surgery, and it's still a little bit hard for me to understand what's the real value of that thing.
Yeah. So the biggest thing I tell my patients, so compared to laparoscopically, the laparoscopic instruments are very useful, but they're straight sticks. So if you think of a pen, right, it's a straight instrument, and you can't bend anywhere on this. So you still can move everything around where you need to, but if you get into a tight corner, you're near the colon or gallbladder, and you're trying to work an angle, your angles are limited because you're working with a straight instrument. The robot gives you a wrist. And so
Mhm.
it allows you in a tight spot to then manipulate and gives you more, the robot has more dexterity even than your own wrist, which
So,
is fantastic. There's times.
like a finger. Is that what it is? It bends.
Well, so it still has, has most of the instruments have like a grasper at the end of it that we're using, or scissors or whatever it may be.
Mhm.
So it really then, think of like a pair of pliers. So
Okay.
a laparoscopic instrument will open and shut normally, but if you got into we're fixing a car, if you're in a tight spot, you want that pliers to make a right angle. You can't do it without moving the entire set of pliers.
Okay.
The robot gives that pair of pliers an angle to it, so you can then work in a tighter space and gives you a lot more dexterity to do a lot more things inside the belly and in tight spaces where the anatomy can be tough, and really gives you that extra angle and range of motion, which can be really helpful at times.
I mean, how many robots does Aultman have?
So currently, the main hospital has 2. Oroville has 1. And last I heard, I believe we're in the talks for possibly a 3rd at the main campus.
Wow. What about the cancer center? Is that useful? These devices useful in that area?
Yeah. So, I mean, again, the cancer center is, I don't really go over there. That's mostly for, where our oncology docs work. So our radiation and chemotherapy docs. But obviously that's all part of all of this, because the surgeons work closely with the chemo and radiation docs
Sure.
for any of these diseases, whether it's breast or colon or whatever cancer you may have.
Okay, Doctor. It is the bottom of the hour. Time for the news. Thanks for joining us this morning on Health Matters with the Medicine Center Pharmacy. Hi, welcome back to Health Matters with the Medicine Center Pharmacy. This morning we are talking with Dr. Chase Beach with Aultman General Surgery.
All right, doctor, before the break, we were talking a little bit about robotic surgery and how it helps you do your job with more precision is my interpretation. Do robotics seem to be expanding, and is it the way of the future in surgery?
Yeah, I think it's definitely heading that way. And more facilities are getting these, more and more residents are getting trained on it. And they're becoming a little bit more affordable. And so for hospital systems, it's obviously, that was the biggest cost to even some of the small guys is getting one of these machines, because they're not cheap. But all of that is getting better and better. And so I think they're becoming more prevalent. Just to give an example, I didn't have really any robotics training in my residency. But over the past, 2 years here at Aultman, I've been, really increased those numbers, pretty substantially. I was laparoscopic trained, so, I've done all of these procedures minimally invasively. And so none of these procedures are new to me, but adding the robot, from my standpoint, has been a benefit to me, especially with, being able to do some of these with these smaller incisions and getting patients up and moving a lot faster. It's helping out tremendously.
So can you paint a picture for us? I think that many listeners may have the vision of surgery like you see on Grey's Anatomy or something like that, where you got a whole bunch of people standing around a table, and the hospital on fire and all these other crises are going on. But, where are you positioned in relation to the robot, and what's that scene look like for a listener?
Yeah, good question. So, I mean, typically, if you think of an OR as probably like a 20 by 20 room, once I scrub in initially and we place the ports, those are what's used to what we call dock the robot to put the instruments into the patient. Once that is done, I then am I break scrub, so I'm no longer sterile, and I sit at the console. The console is in the same room as the patient, the same room as the machine. And that console then controls the robot that's at the patient. So at any point in time, even in our bigger room, I'm still within 10 feet of the patient at all times. And then there's at least 2 people that are scrubbed in at the patient's side to help kind of remove instruments, put new ones in, and to assist me that way. So there's always an assistant that I have at the table, as well as a scrub tech that's helping, pass instruments. And so that's the basic team, but there's obviously anesthesia there to help keep the patient comfortable and asleep.
Mm-hmm.
And then a circulator that if there's something that's not in the room that we need, that is keeping track of things and getting things if we need.
What other types of surgeries can be done robotically?
Yeah, so they're expanding every day. Almost every surgical specialty is starting to get into it. So anywhere from, a lot of the OB-GYNs are doing their hysterectomies robotically. Urology uses them a lot for their prostates, kidneys. Some of the chest surgeons are getting trained for different lung, lung removals or lobectomies, removal of a lung cancer. They're doing those robotically. So pretty much almost everything is getting there. Obviously, if it's inside a cavity, whether it's the chest or the abdomen, is the biggest thing where this is really becoming more and more prevalent.
How much training do you have to get an additional certification?
Yeah, good question. So yes is the answer. So like I told you, I didn't do any robotics training in my residency. So all of this has been after my initial training and after I was already in attending. But as soon as I knew I was coming to Aultman in probably January or February before I had graduated, I very quickly got on board and I started putting time in on the robot over here. Since I was just in Akron, if I had time off, I would drive down here and coordinate with the robotics rep and say, hey, is the robot available? Can I come and practice? The nice thing, the robot actually has some simulators built into it, which is nice. So you can do some practice surgeries, and there's different training programs, as well as we do what's called some dry box work, where they actually set up a fake patient. So they have this it almost looks like a turtle shell. And you practice on putting in everything, and you dock the robot, and then you can practice suturing with real suture and just like you do as a med student with kind of fake scan and different things. And then they always send you down, once you got enough time on that kind of stuff, they send you down to one of their hubs. The one I went to was in Atlanta. And you do a 3-day course, 2-3-day course down there, and they teach you kind of the basics, and they go through everything with you and make sure that you're up to speed before you start doing anything on real patients. And then after that, then you're proctored. So you have to do a certain number of patients with another robotic trained surgeon that is sitting there with you. Usually they have their own console, so they can see and do things as well at the same time. And monitor you, and then at that point, once you're proficient enough, then you get signed off and you can start doing them on your own.
Yeah, doctor, I remember years ago that with the hip replacements and stuff like that, the salesmen were actually in the surgery suite doing the surgery, and they got teaching the doctors how to do it. How about the How about the salesman for the robots? He and they're doing the surgery.
No, but I'll tell you, some of those guys, they have to know their stuff. It's same kind of thing.
Sure.
Obviously we, being going through med school, we know the anatomy and all of that stuff, but some of these reps, they have to know their stuff, and they put their time in for sure. Because if there's an issue with anything, then they're the first ones we ask.
Okay, I just thought I remember that it was just crazy because of the new hips and the new knees and the new types of stuff that is happening. But in that sort of surgery nowadays, certainly robotic surgery is done in orthopedic things too, right?
They're correct. Yeah, they're doing some of that as well. I don't know. I can't speak as intelligently on that stuff as I can about more of the chest and belly stuff, but I know there's a couple different robots that they use for their procedures, which I assume are overall fairly similar, but I don't know the kind of the nuances of some of the joint surgeries that they're doing with the robot.
Sure. So I understand you see patients in Canton and Dover also.
Yeah, so actually, as I was talking to Brad about, unfortunately, the Dover office has recently, in the last few months, we shut it down, partly due to I was out there a couple times a month, and oftentimes it was unfortunate that I was seeing less than 10 patients
Hmm.
for those 2 office days. And then, like with everywhere else, we're a little short staffed. And so I was taking
Sure.
2 people down there with me. And so we've kind of pulled back from that. I was down there for a year from January until December. And it just never picked up, unfortunately, the way we were hoping. But I'm still more than happy to see patients, but unfortunately I won't be able to see them in the office down in Dover.
See. Okay. So how many surgeons are in your group? Between you and your, well, you're not going to Dover anymore, but Massillon, are you going to Massillon and Orville?
Yeah, so I'm not personally, but so there's it's a little complicated here at Aultman, but there's there's 5 in my group, and then there's another group of general surgeons across the hall. So technically there's 7 general surgeons here at Aultman total. But I can speak more intelligently about my partners. Between the 5 of us, we have offices here in Canton, and then Massillon and Orville. Dr. Lafferty and Dr. Biscani are out at Orville, and they actually do surgeries, including robotics, out there. And then Dr. Lafferty and Dr. Roberts are out at Massillon.
How long does a typical gallbladder surgery or colon surgery, how long does it take?
Yeah, gallbladders 30 to 60 minutes ballpark.
Okay.
Part of it depends on how much inflammation there is. There's always a joke in general surgery that gallbladders are like a box of chocolates. You never know what you're going to get.
Okay.
Because you can have a patient that comes in as an outpatient. They've been having symptoms for 5 years. They finally figured out it's from their gallbladder, and you get in there and it's half dead. And you're like, this is a mess. How is this guy walking around every day with this gallbladder? And other times they get in there and it's the anatomy's clean and the inflammation is minimal. And it can be a little difficult to predict, even with, all the ultrasounds and CAT scans and workup that we do. It's a little bit of the roll of the dice sometimes. So 30 to 60 minutes is a good ballpark for an outpatient gallbladder. When it comes to a colon surgery, that's a little bit longer. And part of it depends on, the bigger risk factors, including, is there recent infections, obviously body habitus plays a role in some of that. And how much intra-abdominal fat there is that can make the planes a little bit more difficult, but 1 to 2 hours, depending, maybe a little bit longer, depending on what kind of anatomy and everything is looking like for a colon surgery. But so 2 hours ballpark.
I remember years ago when I had my gallbladder out, I think I was off work for a week or longer to recover. Is that the thing today, or?
Yeah, so I like to tell people, especially if we're able to stay with those small incisions, the first few days are always the worst.
Sure.
No matter how you slice and dice it, whether it's the big incision or not, it's going to hurt. The first few days is just a little bit rocky. The biggest thing we always worry about after surgery is making sure you're not lifting a lot of weight. So most surgeons will tell you, really, as long as you're not lifting a lot of weight, if you have a desk job and you feel up to going back to work, I don't tell my patients no. If you have surgery on Friday and you really need to get back Monday and you're just sitting at a desk, you're not going to hurt anything by going. Are you going to feel up to going is a different question. You'll probably still be sore and, feel a little under the weather. So ballpark, I tell patients, if you can get 2 weeks off, great. If you can't, then we can work with you as long as you're watching that weight limit.
Is the prostate surgery either more invasive or more difficult on the patient than, say, gallbladder or?
Yeah, so I don't do prostates, but
okay.
So I couldn't really speak super intelligently on how those patients do in terms of their post-op care. But in terms of, if I had to compare colon surgery to like a gallbladder, colon surgery usually requires an admission after surgery. We don't. We like to make sure that patients are eating and drinking okay. It's a little bit bigger surgery. You want to make sure that their pain's controlled. Gallbladder is usually a same day procedure, so you come in and go home the same day, because it usually doesn't affect the GI system nearly as much as removing part of your colon. So we're a little bit more hands-on when it comes to the colon stuff.
Well, when we come back from the break, I want to ask you about radiation and
Okay.
surgery. Okay.
All right.
The final break is here. You're listening to Health Matters and with the Medicine Center Pharmacy. Welcome back to Health Matters. Welcome back to Health Matters and show today. And Dr. Beach is really great. So we're going to talk a little bit here about radiation, and I have a situation that I want to lay out. Okay.
Okay.
Some years ago, okay, a local guy was radiated in his mouth,
Mhm.
and then they did surgery on him. And of course, nothing would heal, as you should certainly know. And so he ended up with hyperbaric oxygen. Okay, and that was just a child when this happened. I mean, they were using an old iron lung where he went from the polio days. So how often do you encounter something like this? That maybe the patient has been radiated, and hey, we got to cut this out.
Yeah. And it happens. Perfect world, you'd always love to do surgery before radiation, but there are certain cancers, specifically, rectal, where doing preoperative, chemo radiation is the best option to shrink as much as you can before you're getting in there to remove things. Those are all, very well studied things. That's the most obvious thing I can think of, but yeah, it can create its own set of issues. But the goal is, if you can shrink and get a great response from some of those treatments, it increases survivability. And so as tough as it can make the surgery sometimes, because obviously irradiated tissue is completely different from non-irradiated tissue. Mm-hmm. Irradiated healing is obviously, can be an issue, but all these people that are a lot smarter than me and study this stuff for a lot longer than I have said this is the best way to do it. And if you can shrink some of that stuff before you get in there, the outcomes are better. And so that's the standard of care. So it can be a little tricky sometimes, but it seems to give us the best options to get people healed and cancer free.
I guess I thought when I was thinking about this years ago, and this guy was telling me that, I really felt bad for him. And he got to telling me, he said, well, they put me in an iron lung. I said, what put you in an iron lung for? You have the radiation in your mouth. He said, well, that's the way the therapy works.
They're still doing some of that. Some of the wound care docs will still do some of those hyperbaric chambers and have good results from it. And fingers, crossed that I haven't had anybody that I've needed since I've been out.
Sure.
That's needed it, but even just with any complicated wound that you're having trouble getting blood flow to, there are they're showing some benefits to some of that stuff.
Well, surgery certainly is far more sophisticated today than it was 30 years ago. And other things that were done 30 years ago would never consider doing today, for sure. So very interesting. Go ahead,
Doctor. I'm just wondering what, clearly you're in an environment where there's a lot of change and a lot of new research coming at you and maybe new procedures and new tools. What excites you about the future of surgery, whether it be robotic or general, and what challenges you to learn more and improve patient care?
Yeah. So for me, just like we've talked about, most of this interview is the robot. Obviously, I didn't get to use it at all during my training. And so being able to add that to my skill set has been fantastic. So the next thing that really gets me excited that I would like to be able to get more into is some of the more complicated, maybe hernia stuff. There are a lot of patients nowadays that have had multiple surgeries in the past, and their abdominal wall is not nearly what it used to be or what it should be, and they're having all these complicated hernias. And so some of that stuff can be tough to tackle. And I think the robot gives you a lot of flexibility with some of that stuff. Obviously, some things I still said to the experts that are doing that stuff day in and day out. But I would like to be able to offer a little bit more of that stuff in the near future. So I'm looking at trying to do a little bit more training with some of that stuff and be able to help some of those patients locally if I can.
Do patients come to you and say, "Don't touch me with that machine"?
I haven't gotten as, the nice part about being here at Aultman is that the robot has been here for a fairly decent amount of time. I'd have to double check on when they brought it here. So there are very few patients that come into my office that don't expect at least a little bit about that, or have done a little talking to friends and family and be like, yeah, they're all those guys use the robot. So I haven't gotten that pushback, for better or worse, but everyone's very receptive in terms of, what are the questions? What is the benefit to doing this laparoscopically versus robotically versus open? And as you can attest, if you can keep those incisions smaller,
Sure.
that decreases your scar tissue, decreases your post-op pain, decreases your infection risks. And the robot is just a little bit of added benefit for some of that stuff. And it can really, help things out. Just as an example, for an inguinal hernia, which is another common procedure that we do all the time. Laparoscopically, if I'm doing an inguinal hernia, I have to use 4, maybe sometimes 5 incisions, sometimes 6 if I have to do both sides. And granted, they're all small, about maybe a little bigger than your thumbnail at most. But if I have the robot, I can do both sides, both inguinal hernias with 3 incisions.
So on the robot, you got the camera, right? I mean,
correct. Correct.
Okay.
Yep.
It's not in there, not in there moseying around.
No, I promise. So that's just like one added, aspect, is just a, brief example that even though laparoscopic is similar and has the same size incisions, I can do it with a lot less and a lot quicker and a lot more efficiently with the robot.
Very interesting.
How about do you have any parting thoughts about colorectal cancer and being proactive to get your screenings, and maybe just some tips for the general public who, like that gentleman, unfortunately, you mentioned, put it off for too long and found himself in trouble?
Yeah. And it's unfortunately all too common, it's one of those things, it's so far back in our minds sometimes that if it's not broken, don't fix it. Don't have any symptoms. Why do I need to do all this stuff? And so it's tough sometimes to take some time out of your day to get that scheduled, to do the bowel prep and to do all those things. But it's a much easier thing to do, to be proactive about this kind of stuff. And obviously easy for me to say because I'm the one recommending all these patients to do it. And you still hear every once in a while a patient will say, I don't want to get that done. I've heard stories, things have changed pretty significantly in terms of the sedation that some patients are getting for these. So I truly would tell you 99% of the patients that I have will agree with me, that will say that the worst part of the colonoscopy is the bowel prep, because you're just trying to clean yourself out and you have to spend a day at home and it's, drinking that amount of liquid and, it's just not something you necessarily want to sign up for. But the procedure itself, you sleep through it. There's very little discomfort. Some patients will have a little bit of bloating from the gas, but usually the average patient really has no problems. And it's a very simple in and out thing to do. It's a same day procedure, and can really set you up for long-term colon health and prevent these things from causing a problem in the future.
It's the thing that just kills me is some of the people say, I got to have a big dinner tonight because they're going to have to clean me out tomorrow. They're doing colonoscopy. I'm going to have a steak. And I'm
it's that last meal concept.
I know, this is my last food.
Right.
My last meal and whatever.
I'm gonna right. So it happens all the time, but it is what it is. It's hard pressed that I wouldn't do the same thing, but
liquids, man.
As long as you're getting cleaned out and you're doing the bowel prep, as long as you're doing the bowel prep, it should take care of it, no matter how big that last meal was. But
okay, I think we're out of time, Doctor. Okay, hey, great having you on the show. I
appreciate it.
Great having you on the show.
Thank you.
Thanks so much.
Thank you to our guest, Dr. Chase Beach, general surgeon at Aultman General Surgery. We would like to remind our listeners, if you suspect you have a medical issue, please contact your healthcare provider. Thanks to our sponsors, Aultman Health Systems, Studio Arts and Glass, January Appraisals and Liquidations. As always, we thank you, our listeners, for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week, and we'll see you right here next Friday on News Talk 1480 WHBC. Thanks very much, Doctor.
Thank you.
The preceding program is
Excellent
sponsored by
show.
the Medicine Center Pharmacy.
Appreciate it, guys. Have a good one.
Take care.